Welcome to Medical Dialogues. I am Dr. Nandita Mohan, and today we welcome you all to the Right Turn show, where we will focus on the optimal use of Dapagliflozin and its combinations in specialty care settings. Now, Dapagliflozin is a popular choice among doctors for managing T2DM and also plays a very crucial role in treating heart failure and chronic kidney disease. Now, with that context in mind, let's explore some of its clinical applications. We have with us today two experts, one Dr. Johann Christopher, a renowned cardiologist at Care Hospital, Hyderabad, also the Director of Multimodality Cardiac Imaging Care, the Joint Secretary of Indian Academy of Echocardiography, Board Director of Asian Society of CV Imaging, Executive Secretary IACI, Vice President WCC ICC Mumbai, and a national speaker on cardiac imaging. We also have with us Dr. Bipin Sethi, who is a consultant endocrinologist at Care Hospital, Hyderabad. Welcome to Medical Dialogue, sir. It's really a pleasure to be interviewing you both here today. So, Dr. Johann, my first question to you is, what are some of the unique benefits of Dapagliflozin in cardiology settings for T2DM patients?
Yeah, so Dapagliflozin is an interesting drug. It started off as a sugar molecule rather than an endocrine molecule because we were all looking for something that would have a CVOT benefit after the problems with rosiglitazone. And in this unique sort of formula, we did discover a good drug for gravity for full HbA1 reduction. But in the path when we were using it wrong, what we also saw was there were very good signals for cardiovascular benefit and protection. And when we explored this further with the various trials, we found that it had an extraordinary benefit in the reduction of heart failure hospitalization through the DAPA-HF trial. And we were also within some cardiovascular outcomes 2 point against the declarately trial. And when we further explored this thing, we found that it was giving really protective effects for DAPA-CKD trial. So a clinical benefit in terms of cardiovascular measurement, heart failure reduction, and renal protection. And that completely swung the pendulum from just being a focus drug to become an explosive failure or cardiovascular molecule, which was then designed for diabetics, but also bringing it down against a non-diabetic patient and became truly a heart failure or a cardiovascular molecule. So we were really lucky to be part of this journey, and I know that Dr. Bipin spearheaded this journey right from the inception, and we were lucky to get along this time. And we see truly changing the lives of many of us.
Thank you for those insightful points. Now, turning to Dr. Bipin Kumar Sethi, considering the treatment goals that have been transitioning from glucocentric to metabolic goals in T2DM care, what are the right turn or rather the favorable cardio-renal metabolic benefits of the use of Dapagliflozin in T2DM patients?
Well, you rightly put it. We realized long ago that controlling glucose does not give benefit to the vessels. So the macrovascular disease, so to say, were not reduced by the pivotal trials that were done with the intent of glucose control. The only thing that we learned from those trials is that glucose is one of the factors that controls these diseases, and for a macrovascular benefit, one has to institute therapy early, continue it for a long time, be aggressive, and we will see very delayed impact, because even in the time of UKPDS, when the lipid-lowering agents were not really great and the antihypertensive therapies of the type and kind that we have now were not available, we realized that early intervention does provide benefit for macrovascular disease only after a couple of years. We then started focusing later on control without hypoglycemia, without weight gain. And when the trials with SGLT inhibitors were about 9 years ago, I think September 9 years ago in the EST, when for the first time the results of the first SGLT inhibitor were announced, we were glad to note that for the first time we had a molecule which gave us a cardiovascular benefit. Earlier to that, we had GLP-1 analogs, but they were injectable. They had issues of tolerance and also cost. And this was for the first time that an oral molecule, the molecule was empagliflozin, did show a reduction in the major adverse cardiovascular events, driven largely by death, cardiovascular death. The dapagliflozin people were quick to catch on the secondary endpoint, which was heart failure, and the declared TME, which Johann just alluded to, they made it a co-primary endpoint. And lo and behold, this drug was the first drug to get an approval for reduction in heart failure because that was a co-primary endpoint, the declared TME trial. Subsequently, as he has mentioned, trial after trial has shown that these molecules are of benefit in diabetic proteinuria population and also non-diabetic kidney disease as also non-diabetic heart failure. So we have moved clearly from a glucose-centric approach, which is important. We have to reduce glucose for the microvascular complications, and we institute the control very early. And if it is done with a drug that does not cause inherently hypoglycemia, be it SGLT inhibitors, be it DPO inhibitors, we have the opportunity now for the first time in our lives to reach the target of almost non-diabetic range without concern of hypoglycemia, and in case of SGLT inhibitors, even weight loss can be achieved. So I think this is a welcome move, and this gives an impetus to patients and healthcare professionals alike to just strive for reaching targets as low as possible, as safely as possible, and protecting the tissues, not just the microvascular, but also the macrovascular tissue. So I think we are in, as Johann just mentioned, very exciting times when we can offer control without major concerns if we have taken care of side effects and chosen the agents properly.
Great points, Dr. Bipin. Now, back to you, Dr. Johann. As we see, the use of the fixed dose combinations is becoming increasingly common. Do you think the dapagliflozin sitagliptin dual combination has relevant applicability, especially in cardiology settings?
Yeah. Again, I will just allude to one of my senior colleagues' experience. In fact, Dr. Bipin's experience many years ago, where they understood the Indian population, the problem of adherence, and they were using fixed drug combinations for quite some time historically, when the Western world was very particular about giving drugs separately. But now we find in the guidelines across the board that whether it is a diabetic molecule, a heart failure molecule, or a hypertension molecule, across the Atlantic, the guidelines are pushing for combination therapy. That means you start with a combination single, go to a triple, and then you add on the other. So this is a trend which is widely copied because we know that non-communicable diseases are long-standing. They require more than efficacy. They require a long time. So poly pills cannot be developed. Everybody's got a very busy lifestyle. So we are here again on the realm of combination preparation. Now, when we look at sitagliptin, we have been again lucky, thanks to Dr. Bipin's guidance, that we were in the trial which used sitagliptin many years ago in India. Unfortunately, due to various regulatory issues, it never came back till recently. So we were involved in the glucose trial, where we found for the first time a cardiac neutrality, cardiac safety was involved. There was no red flags when using this drug in patients with ASCVD. There are a lot of the other nations we started showing red flags. So, in a molecule composition, completely safe with a large proportion of ASCVD patients. And if I remember, the CKD population is very minimal. There was no ASCVD. There was no red flags in terms of safety. The second thing is that it has an OLE triplet, OLE means once daily, which matches the time curve for hypertension, which is also once daily. And the third thing was that the mechanism of action is complementary and has a synergistic benefit on sugar control because it acts directly on the pancreas and improves the insulin secretion and also the presence of glucagon peaks. So that is subversive in contrast to the pathologic mass which works through the kidney. So you have two drugs with similar pharmacokinetic, complementary to each other in terms of structure, and complementary to each other in terms of mechanism of action, and therefore it is a very good synergistic benefit. So you have all the cardiological benefits population we've just talked about, and then you have a painkiller like full which does not have the benefits, which is completely safe. And sitagliptin is also non-sugar, weight neutral, and with a fairly good HbA1c reduction. And if you look at the HbA1c of most of the CBD, they've long passed on where it's going to really act. So dual it is important to get the one which is the pulmonary effect. And then you're getting all these synergistic. So I think it's a very valuable, important combination, and most importantly, it's extremely safe.
Very insightful. Now, for some endocrinology perspectives, Dr. Bipin, could you share with us after how many years approximately do Indian T2DM patients fail to achieve their glucose control with these two agents, and what actually are the considerations and the need for the triple agents in such patients?
Thank you. See, the diabetes that we understand, which we are talking about type 2, is on account of progressive decline in the beta cell function in individuals who have started with a genetically defective beta cells. So the rate of decline of beta cell function is different in different people. So it will be difficult to say a particular number, but enough to say that all these people require monitoring to test the efficacy of the molecule that is given, because sooner or later the chosen molecule will not be able to provide glycemic control. There are, of course, trials which say that if you are drugs from the very beginning, you might be able to achieve target for about 4 to 4.5 years without having the need to resort to another molecule. And there was a study in that regard in Verify. But given all that, maybe by about 5 years or so, most people who are being treated for type 2 diabetes mellitus would not be able to control these drugs, their glycemia with 2 or more drugs, which means that they would be requiring additional agents for glycemic control. And the propensity of doctors now and patients alike is to choose drugs that do not cause hypoglycemia, that do not give much weight gain or actually produce weight loss, and have some other benefits in terms of blood pressure control. So we have, as Dr. John was mentioning, drugs like metformin, and you add on to that SGLT2 inhibitor or with a D4 inhibitor. So you can then sail the patient through the turbulent waters of hyperglycemia for a considerable period of time with good control. And initial control is very important. If you go by the data of UKPDS, whatever control the person achieves in the initial years really determines what happens afterwards. In the people who received the intensive treatment in that trial, even when their HbA1c at the end of trial was sort of drifting away from the target, and similar to the people who were on conventional therapy, these people continue to enjoy the benefits of glycemic control. And the UKPDS authors call it the legacy effect. Therefore, it's very important that we strike early and see that these patients don't drift, because instead of putting a number that is 2 years, 3 years, 5 years, one should not be complacent, because an individual person trajectory may be different, and one should be always ready and prepared to look after the consequences of declining control, so that the person remains in euglycemia for as long as is possible to enjoy the benefits of an early intensification and remaining in targets rather than late intensification and achieving target when it is of no use. It has been said many times over that for any problem to be solved, one has to intervene right in the very beginning, because intervention later will change the numbers but not protect the tissues, be it micro or macrovascular.
Excellent. Now, Dr. Joanne, moving back to cardiology, do you think dapagliflozin, sitagliptin, metformin triple combination has relevant applicability in cardiology settings?
Yes, see, metformin has been a historical go-to molecule when we never had these other agents. In fact, if you ask me of all the drugs, then for the diabetic armamentarian, the only drug the cardiologist really knew many years ago was metformin, simply because it was safe, it was good for our obese patients, it was known as an insulin sensitizer, and it had a very easy dosing because people goes in red sheets, it creates 500, 850,000, so it is very easy for cardiologists to use. It has been our go-to molecule for a long time. Anything more, we would write to Dr. Bipin to see. That was our default response. So we have a lot of experience on metformin just because of having used it. We also know that it's great in obese patients. We also know that it's a very clear ability in someone with a acute kidney injury and things like that. So metformin is always on the card because when you look at the ominous observation in terms of hyperglycemia, when you add a metformin, it increases hepatic lipid production and improves sensitivity. And then you have sitagliptin in the separation, and then you have which things like sugar formation. You have three drugs that discuss mechanisms action. All of giving is a sort of formulation to get the HbA1c down. So it is already discussed that all patients because are pretty high because of the high carbohydrate diet that we have. So even thinking of somebody being income will please that they are almost impossible. So dual therapy or multi therapy is built to spirits. The good news is that all of these drugs are safe when you get put together. The bioelectricity is good. They work to different mechanisms. But therefore, there is a complementary and serious connection. And the best part is all of them have a very good result of the neuroacid, which is again a big problem in the long drugs. Compared to, for example, the sulfonylurea, which would be a little dangerous. So these three drugs are very safe. They have their own benefits. Dapagliflozin obviously has most. And when you're coming up with a high HbA1c, before you take the next step from this one, I think this is a great combination, and we have used this combination in multiple patients, which is very good effect.
Thank you. Now, Dr. Bipin, my last question for you is: which clinical scenarios are appropriate for considering the dapagliflozin, sitagliptin, metformin use?
I think John mentioned that the benefits which are applicable to the kidney and the heart are on account of the dapagliflozin component largely. But that's the only molecule that has shown in a large number of patients benefit in these settings. So if you are to say that which kind of patients are going to get benefited from this and which is the patient profile, the only problem in this scenario is that sitagliptin is a drug which requires dosage modification in renal insufficiency. And at that point of time, the dapagliflozin is effective in renal and cardio protection, but is not a good anti-hyperglycemic molecule. So if I have to see this molecule as an anti-hyperglycemic therapy, probably it should be introduced earlier on in the disease management when renal impairment in terms of decreased GFR below 50 is not a concern. Obviously, this molecule, if it is being used for pure cardio-renal benefit, probably there will be a subset of people who would not be having the GFRs of the type and kind that will permit a full dosage of sitagliptin. But coming back to your question, any patient who is, let's say, not controlled with metformin, which is an initial therapy for most people, and whose HbA1c is say 1 percentage point above the target that we have for the patient, it is better to do two drugs rather than one drug, which means sitagliptin and dapagliflozin or any D4 inhibitor and any SGLT inhibitor. There could also be a scenario wherein a patient is on two drugs, could be metformin with SGLT inhibitor or D4 inhibitor who is not on target, and you can then add the agent which was not there. That means patient is already on metformin DP4, add SGLT inhibitor, or if somebody is on SGLT inhibitor, metformin, you add D4 inhibitor. So on the dual drug combination, if somebody is failing to achieve target and HbA1c say about 0.4, 0.5% points away from the target, then I think we can always use this. Or there could be a patient whose HbA1c say 8.5 to 9 at the very, very beginning, and we are very sure that this is not type 1 diabetic, the patient is not symptomatic. We can consider triple therapy right in the beginning. But as things happen, most of the patients who are being selected for this kind of therapy are those who are failure on metformin and require two drugs, or who have failed to respond to dual drug who require a third drug, or who are stable on a combination of metformin, SGLT inhibitor, D4 inhibitor individually, and who want, as Johann said, reduction in the pill burden to improve their compliance. Then that category of people will come. But as I said, one should be very, very careful that their GFR is of the type and kind that permits full dosage of sitagliptin. I assume that we are talking about a molecule which delivers 10 milligrams of dapagliflozin, 100 milligrams of sitagliptin, and 1000 or 2000 milligrams, whatever you have for metformin. So in that context, these are scenarios which I think we will be using this molecule for, but one should be very, very careful that the patient's GFR permits the dosage of metformin, because even metformin under the GFR of 45 would require to be reduced to about 1000 twice daily, and below 30, of course, there is no point in using metformin. So all these things considered, this combination will have a great role to play in younger patients, younger in terms of their disease duration, wherein they have not yet had issues of GFR decline.
Thank you, Dr. Johann. Thank you, Dr. Bipin, for sharing your valuable insights today. We've actually had a very comprehensive discussion on dapagliflozin and its role in managing T2DM, from both its unique benefits, both in cardiology as well as endocrinology settings, to actually the practicalities of combination therapies. So thank you so much for joining us today at Medical Dialogues.